Sasagliptin drug reaches maximal concentration within 2 hours or 4 hours for its active metabolite. It is minimally protein bound and undergoes hepatic metabolism by CYP3A4 or 5. The major metabolite is active and excretion is by both renal and hepatic pathways. Terminal plasma half-life is 2.5 hours for sasagliptin and 3.1 hours for its active metabolite. Adverse effects include an increased rate of infections, such as upper respiratory tract and urinary tract, headaches and hypersensitivity reaction, urticaria or facial edema. Linagliptin is primarily excreted via the bile. No dosage adjustment is needed in renal failure. Lowers hemoglobin A1C by 0.4 to 0.6%. Adverse reaction include nasopharyngitis and hypersensitivity reaction, urticaria, angioedema, localized skin exfoliation, bronchial hyperactivity, and the rest of pancreatitis may be increased. Allogliptin lowers hemoglobin A1C by about 0.5 to 0.6%. In clinical trials, pancreatitis occurred in 11 of 5,102 patients on allogliptin, which is 0.2%, and in 5 of 5,183 patients receiving all comparators, less than 0.1%. There have been reports of hypersensitivity reaction, anaphylaxis, angioedema, Stevens-Johnson's effect, or syndrome. Cases of hepatic failure have been reported, but it is unclear if allogliptin was the cause. Sodium glucose cotransporter 2 or SGL2 inhibitors. So works by inhibiting SGL2 in the PCT or proximal convoluted tubule to prevent reabsorption of glucose and facilitate its excretion in the urine. So examples are canagliflozin, reduces the threshold for glycosuria from a plasma glucose threshold of approximately 180 milligram per DL to 90 milligram per DL. It has been shown to reduce hemoglobin A1C by 0.6 to 1%. The fagliflozin reduces hemoglobin A1C by 0.5 to 0.8% when used alone or in combination with other oral agents or insulin. It is also results in modest weight loss of about 2 to 4 kilograms. Other hypoglycemic drugs. Pramlintide is an islet amyloid polypeptide IAPP amylin analog. IAPP is a 37 amino acid peptide present in insulin secretory granules and secreted with insulin. Approved for use in insulin-treated type 1 and type 2 patients who are unable to achieve their target postprandial blood glucose levels. It is rapidly absorbed after subcutaneous administration. Levels peak within 20 minutes and the duration of action is not more than 150 minutes. It is metabolized and excreted by the kidney. Colicivilam hydrochloride. The bile acid sequestrant and cholesterol-lowering drug is approved and as an anti-hyperglycemic therapy for persons with type 2 diabetes who are taking other medications or have not achieved adequate control with diet and exercise. Bromocriptine, the dopamine agonist in randomized phase to be controlled studies lowered hemoglobin A1C by 0 to 0.2% compared with baseline and by 0.4 and 0.5% compared with placebo. The mechanism by which it lowers glucose levels is not known. The main adverse events are nausea, fatigue, dizziness, vomiting, and headache. Colizivilam and bromocriptine have very modest efficacy in lowering glucose levels, and their use for this purpose is questionable. So combination therapy for type 2 diabetes. So combination therapy is a treatment that uses two or more medications to address various health conditions such as type 2 diabetes. Type 2 diabetes is a chronic disease that occurs when sugar levels rise as a result of problems with the use or production of insulin in the body. So combination treatment for type 2 diabetes mellitus. First is sulfonylurea plus biguanide, glyburide plus metformin, glucovans, which is glipizide plus metformin, and metaglep. Dinadayon plus bigwide, rosiglitazone plus metformin, avandamet. So glucagon mechanism of action. Polypeptide counter-regulatory hormone secreted by alpha cells of the pancreas and stomach. It increases STAMP or cyclic adenosine phosphate, GPCR coupled to GS proteins that stimulate adenyl cyclase activity to produce increase of cyclic adenosine phosphate. Inhibits PDA or phosphodiesterase inhibitors activity to prevent cyclic adenosine phosphate breakdown. Clinical effects: liver tissue, promotes hepatic glycogenolysis and gluconeogenesis to raise BG levels, requires hepatic glycogen stores, delayed effect, increase BG levels, promote insulin release, gastrointestinal tract, decrease motility, relaxes smooth muscle of the stomach, duodenum, small bowel, and colon. Heart is increase of cyclic adenosine phosphate, increases heart rate contractility, and BP. Max chronotropic effects dependent on circulating ionized calcium. Hypo and hypercalcemia blunt max response. Mini glucagon, arachidonic acid release, increased cardiac contractility. Cardiac tissue metabolizes glucagon to mini glucagon. Arachidonic acid affects calcium to increase contractility. Effects decrease with severity and chronicity of CHF. Not dysthermogenic. Not dysthermogenic. Indications: hypoglycemia, intravenous intramuscular subcutaneous was 1 mg, may repeat in 15 minutes PRN. Give IV dextrose ASAP delayed effect, diagnostic aid relaxation of GI tract. IM equals 1 to 2 milligram, IV equals 0.2 to 0.75 milligram. Indications of label: BB or CCB induced myocardial depression, which or without hypotension, unresponsive to standard measures. IV equals 3 to 10 milligrams or 0.05 to 0.15 milligram per kilo. Bolus infused over 1 to 2 minutes followed by infusion of 3 to 4 milligram per hour or 0.05 to 0.1 milligram per kilo or per hour. Only follow with infusion is response to bolus. Titrate infusion to response. Glucagon versus HDI. HDI means histone deacetylase inhibitors. Animal studies more sustained effect and better survival rate with HDI. So beta blockers overdose mechanism of action. So glucagon increases heart rate and myocardial contractility and improves anterioventricular conduction. These effects are unchanged by the presence of beta receptor blocking drugs. This suggests that the glucagon's mechanism of action may be bypassed the beta adrenergic receptor site. Precautions, nausea or vomiting. Those dependent, anticipate and manage place in lateral recumbent position antiemetics. Tachyphylaxis or desensitization, possibly worse with continuous administration. Decreased gastrointestinal motility may impede decontamination attempts. Hypokalemia or hypoglycemia, insulin secretion, or hypokalemia, stimulation of sodium potassium ATPase in skeletal muscle, hypokalemia, insulinuma, feedback increases in insulin, worse hypoglycemia, pheochromocytoma, catecholamine release, hypertensive crisis. Drug-to-drug interactions. Epinephrine potentiates and prolong hyperglycemia and CV effects. Phosphodiesterase inhibitors, melrinon, amrinon, decrease metabolism of cyclic adenosine phosphate, synergistic effect. Histone deacetylase inhibitors inhibits glycogenolysis and gluconeogenesis. Anticholinergic agents increase gastrointestinal adverse drug reaction. The indomethacin may diminish the therapeutic effect of glucagon, vitamin K agonist. Glucagon may enhance the anticoagulant effect of vitamin K antagonist. That would be all. Thank you.